Welcome to Continuing Mobile Education for Emergency Medical Services Providers. This is Respiratory Issues, Episode 2, Asthma. After viewing this episode, participants will review the pathophysiology of asthma. Participants will also review the identification and assessment of asthma. Finally, participants will review the pre-hospital management of asthma.
Asthma is inflammation of the lower airways, and it is basically, as many people know, a bronchoconstriction. So the bronchioles and the larger airways in the lower airway constrict, and this particularly impacts the expiration of air. Asthma attacks are often triggered by some kind of inflammatory process in children. The most common things can be an allergen, such as an allergy to a cat or a dog or to cigarette smoke. But it can also be caused by a virus like the common cold, or any kind of upper respiratory infection commonly causes asthma exacerbations. There can also be different kinds of asthma, like exercise-induced asthma, and occasionally the weather or the air, the temperature of the air can induce an asthma attack.
Asthma in the pediatric population, I'm finding, is becoming more and more prevalent. We find a lot of people who have smokers in the household, low income, where you might have allergens in the household. Kids are coming to the hospital and presenting to the 911 system with asthma or increased work of breathing.
Asthma causes some physiological changes to the respiratory system. In particular, you find bronchoconstriction, and the bronchoconstriction means there's constriction of the smaller and larger airways in the lower airway structures. And that most commonly will cause difficulty in expiring air. So an asthmatic with these physiological changes may have no difficulty breathing air in, but it takes a long time to breathe the air out because of the air trapping caused by the bronchoconstriction.
Asthma is an inflammation of the lower airways and constriction of the bronchioles. It is associated with a prolonged expiratory phase. It can be triggered by an allergen such as animals, smoke, temperature changes, and physical activity.
The classic presentation of a pediatric asthmatic is usually with shortness of breath. Parents will report hearing wheezing often, but oftentimes there will be a preceding upper respiratory infection or virus, and sometimes a fever. And the parents describe the patient as having increased respiratory distress, to the point where sometimes there will be audible wheezing. But some of the more subtle signs that the parents or you as a provider might notice would be increased respiratory rate and increased work of breathing, with some signs of retractions and increased expiratory phase that you might notice on the stethoscope.
To identify asthma in the pediatric population in the pre-hospital setting, the patient will present with anxiety, frequent cough. It's not barking like you would in a croup situation. You will have inspiratory or expiratory wheezing, accessory muscle use, and most of the time these patients have a history of asthma already.
Key assessments for pediatric asthma assessment is getting a little bit of the history. Does the child have a history of asthma? Maybe look into potentially what could have triggered it. Is there any smoking in the house, pets? Is the child allergic to pollen, dust, things like that? So that kind of gives you like a little bit of history of maybe what could have potentially triggered it. Just looking at the child, can you hear the wheezing? Is the child retracting? How does the child's color look? Is the child able to talk to you in full sentences? Because that's a key element of that a child's in distress. I've had kids who want to talk and talk and talk, but they can't even finish a sentence, and you have to try to tell them to stop talking. There's also kids who will wheeze very loudly and be happy wheezers. So don't think that child's not in distress. We kind of call it a happy wheezer, but they still need the full treatment of the nebulizers. And parents are afraid to fight with their children for a nebulizer. The nebulizer has to go on their face, the mask, and hold it up close. So that's something that's key, is making sure that the child really does receive the treatment, because sometimes that's the case. Maybe they're getting worse because the family's not able to provide them with the treatment well, so they call EMS to assist with that.
Patients with asthma exacerbation will usually present with a history of asthma and possibly a preceding respiratory infection. Patients will experience respiratory distress, shortness of breath, audible wheezing, inability to speak full sentences, and use of accessory muscles, and possibly retractions.
Asthma exacerbation pediatrics is very common, and EMS does a wonderful job. Many times by the time they reach us, they're better.
Pre-hospital management of asthma includes beta agonists. The most common, of course, would be albuterol. Most EMS agencies carry albuterol nebulizers. And some pre-hospital systems also give steroids, and if that's the case in your system, then steroids are also mainstay treatment of asthma because they reduce the airway inflammation that's causing the bronchoconstriction.
To treat a pediatric patient with asthma, it's mostly an albuterol nebulizer, 2.5 milligrams, and you can also give an ibuprofen bromide or Atrovent neb along with it in a cocktail.
There are many tricks that could be used in trying to administer oxygen to a pediatric patient. In the smaller children, blow-by oxygen is usually the most effective, and that's often best administered by the parent because the children are comfortable with the parent. So if it's safe from a vehicular standpoint, you can have the parent in a seatbelt with the child nearby, also seatbelted or in a car seat, and the parent can use a blow-by oxygen near the patient's mouth and nose. Additionally, older children can tolerate a nasal cannula or a face mask. And another way in asthma management to give oxygen delivery is after the nebulizer is done, have the child continue to, quote, smoke the peace pipe, which often providers will tell the children a nebulizer makes a nebulizer fun, and have them continue to do it even after the albuterol is gone, and they'll get more oxygenation that way.
There's a couple different things that EMS can do to make sure that the child's receiving the full treatment, depending on the age. If it's an infant, the infant will keep the mask on most likely, or the parents can hold it in front. Toddler may have to sit between the parents' legs on the EMS stretcher, and I've seen that, and kind of hold their arms down in their legs and keep the mask on their face. Some kids are really completely terrified of the mask, and you can just hold the tube in front of their face as long as they're not moving their head and it looks like they're getting it. And you can tell if their oxygen levels improving as well. And I have seen some EMS providers have different animal-like masks that the kids seem to like. We don't have that in the emergency department, but I have seen that with EMS personnel.
No one case of asthma has stuck in my mind in the pediatric population. I see so many of them, they all seem to blur together. The treatment is pretty routine. It's the albuterol, the ibuprofen, supplemental oxygen. You put them on the heart monitor because of the cardiac effects of these medications. Consider starting an IV in timely transport. Pearls of wisdom for treating pediatric patients is getting the medication in them. Not all kids are cooperative. Putting the nebulizer pipe in their mouth, you might have to do a flow-by. Have the parent hold the nebulizer mask over their mouth or near their face and get flow-by.
Treatment of asthma includes supportive care, high-flow oxygen, and cardiac monitoring. Regionally influenced management includes beta agonists such as albuterol, anticholinergics such as Atrovent, and steroids. Delivery of oxygen or nebulizers can be augmented using the blow-by technique or with the assistance from parents. After viewing this episode, participants will review the pathophysiology of asthma. Participants will also review the identification and assessment of asthma. Finally, participants will review the pre-hospital management of asthma.